In this video, let us study the effects of injury and disease on spinal cord. Before we begin, let us learn a few terminologies. The term quadriplegia or quadriparesis refers to paralysis or weakness of muscles of all the four limbs. The term hemiplegia or hemiparesis refers to paralysis or weakness of muscles of both the limbs on the same side or one half of the body. The term paraplegia or paraparesis refers to paralysis or weakness of the muscles of both lower limbs. Similarly, the term monoplegia or monoparesis refers to paralysis or weakness of any one limb. Let us now learn the effects of injury to the spinal cord at various levels. When the spinal cord is injured at the level of C4, it results in spastic quadriplegia. Babinski sign will be positive. There will be sensory loss below the level of C4 and incontinence will be present. When the spinal cord is injured at the lower cervical level, then upper limbs will show lower motor neuron type of lesion. Lower limbs will show upper motor neuron type of lesion, that is spastic paraplegia. Babinski sign will be positive. Sensory loss will be seen below the level of C5 or C6 and incontinence will be present. When the spinal cord will be injured at the level of T6, we find spastic paraplegia, Babinski sign positive, sensory loss below the level of T6 and incontinence will be present, but in this case both upper limbs will be completely normal. And when the spinal cord is injured in the lumbar region, then there will be low motor neuron type of lesion in the lower limbs, sensory loss below the level of L1 and incontinence will be present. So based on how the patient presents with this lesion, that will tell us the site of injury. Similarly, in case of right-sided dorsal column lesion involving segments below the level of L1, then the patient will have loss of tactile discrimination and loss of position and vibration sense in his right lower limb. Or if there is a right fasciculus cuneatus lesion, then the patient will have loss of tactile discrimination and loss of position and vibration sense in his right upper limb and upper trunk. When there is lesion to the left lateral spinothalamic tract at the level of L1, then the patient will have loss of pain and temperature sensation in the right-sided lower limb because the left spinothalamic tract will be carrying information from the right half of the body. Similarly, if there is a lesion to the right lateral corticospinal tract, let's say at the level of C4, then the patient will show right-sided hemiplegia. So based on this knowledge, let us check a few case scenarios. In the first case, a 75-year-old lady was hit by a cricket ball to the back of her neck. She fell to the ground and was rushed to the hospital. People who rushed to help her reported that she was unable to lift her arms or get up after she had the fall. On examination, there was weakness in both upper limb and lower limbs, impaired pain and temperature sensations bilaterally, and position and vibration sensations were within normal limits. Following detailed examination and investigation, patient was diagnosed with anterior cord syndrome caused by traumatic cervical disc herniation followed by fibrocartilaginous embolization in this case. So what do we mean by anterior cord syndrome? The anterior spinal artery supplies anterior 2/3 of the spinal cord. When this anterior spinal artery is blocked, it results in infarction in the anterior 2/3 of the spinal cord, what we call as anterior cord syndrome. So what will be its effects? Bilateral lateral corticospinal tracts will be involved. That will result in, if the lesion now in this case it is at the level of C4, C5, so it will result in spastic quadriplegia. Bilateral spinothalamic tracts will be involved, so that will result in absence of pain and temperature sensation in the affected region. Please note the fine touch, sense of vibration and position will not be affected here because dorsal columns are not affected in case of anterior spinal artery involvement. Coming to the second case, A 55-year-old lady with history of cervical spondylosis was hit on her chin by her husband the previous night. Next day morning, she observed difficulty in combing her hair and doing her routine chores in the kitchen. She went to the hospital by evening when she realized that she had not passed urine in the last 24 hours. Neurological examination revealed greater weakness in her arms than her legs, reduced touch and pain position sensation in the area below the level of C6, and altered pain and temperature senses in the upper back and arms having a cape-like distribution. A diagnosis of central cord syndrome was made following these investigations. So what is central cord syndrome? As the name suggests, the central part of the spinal cord is affected. Most often it will be following an injury, especially which results in hyperextension of the neck. As in this case, the lady was hit on the chin, resulting in hyperextension. So when you see the area demarcated here, you are seeing that the medial halves of the corticospinal tracts are involved. So that is the area which has the cervical segment fibers, or those fibers which are meant for upper limbs. So the patient will present with more marked weakness in the upper limb as compared to the lower limb. And you will also see that the medial part of the spinothalamic tracts are involved in the affected area. So that will result in the typical cape-like distribution of loss of pain and temperature sensations. With time, the patient may also show fasciculations and atrophy of the muscles supplied by ventral neurons at this level. So this is the lesion at the level of C6. So elbow flexors will be involved here. That will be seen, of course, at a little later stage. Now, coming to the third case scenario, a 40-year-old lady was brought to the hospital by her son for the burn injuries she sustained during cooking to the tips of her fingers of both her hands, although she reported not having any pain associated with the injury. Further neurological examination revealed no other neurological deficits. Discriminative touch and position sense was intact. MRI revealed cystic dilatation of the cervical level central canal, and diagnosis of Syringomyelia was made. So what is the effect of Syringomyelia in the mid-cervical segments? The central canal is enlarged here or dilated. So that will result in fibers of the bilateral spinothalamic tracts which are crossing in the anterior white commissure to be disrupted. So this will result in dissociated sensory loss. That is, the pain and temperature sensory fibers are affected. So the patient will have absence of pain and temperature at that level. But in the same segments, the touch and the position sense, they are not affected because dorsal column is not involved at all. So this is a classic feature of Syringomyelia. Patient has burn injuries, but the patient doesn't feel the pain. Coming to the next case, a 60-year-old lady arrived with stomping gait to the neurologist and presented with a history of pins and needles in her feet, difficulty in walking in the dark, and weakness in her leg muscles since last 3 months. Neurological examination revealed weakness in both her legs, extensor Babinski sign, hyperreflexia, and impaired sense of position and vibration. Romberg sign was positive. So the neurologist prescribed her vitamin B12 injections and asked for follow-up. So you're seeing a set of features here, that is Babinski signs being positive, hyperreflexia, and muscle weakness in both lower limbs, suggesting upper motor neuron type of lesion to the lower limbs. And there is also impaired sense of position and vibration, and Romberg sign positive, and patient had walked in with stomping gait, suggesting dorsal column involvement. So this kind of combination of motor as well as sensory deficits is what is classically seen in subacute combined degeneration or Lichtheim disease. This is usually due to vitamin B12 deficiency. There is going to be patchy loss of myelin in both lateral and posterior column tracts. It mainly affects the corticospinal and dorsal column pathways because they are highly myelinated fibers. Spinothalamic pathways are usually spared. So pins and needles, what the lady was feeling, was due to associated polyneuropathy. So what we see here by the patient's description is Because the dorsal columns are affected, the patient has the stomping gait, loss of position sense and the vibration sensations. And because of the corticospinal involvement, the patient will have weakness in her lower limbs. Coming to the next case, let us assume a hypothetical situation in the movie Bahubali, that Kattappa's stabbing Bahubali in his back had left him alive. And a neurologist got to examine him after his stab wound was healed. So the examination revealed weakness, hyperreflexia, and positive Babinski sign in the left lower limb of Bahubali, fasciculations in his lower trunk muscles, especially the anterior abdominal muscles, impaired sense of vibration and position in his left lower limb, and impaired sense of pain and temperature in his right lower limb. So this is a classical case of what we call as Brown-Sequard syndrome, which is due to hemi-section of the spinal cord. In this case, it's at the level of L1. So one half of the spinal cord is severed. So this results into classic 4 features: ipsilateral upper motor neuron lesion below the level. Now that is seen in the case of, because this is at the level of L1, it is seen as upper motor neuron lesion in the lower limb of the same site. Ipsilateral lower motor neuron type of lesion at the level of injury because of the involvement of ventral horn motor neurons. Ipsilateral loss of fine touch, vibration and position sense, that will be because of the involvement of dorsal columns. And contralateral loss of pain and temperature sensations because of the involvement of lateral spinothalamic tract. So these 4 features together is what we call as Brown-Sequard syndrome, or the effect of hemi-section of spinal cord. Coming to the next case, after a fall from his horse, a 35-year-old jockey was alert but unable to move any part of his body except his head. He was unable to sense light touch or pain from neck down. He could turn his head, but shoulder shrug was feeble. His speech was normal but short, and respiration was labored. So this is a case of complete transection of spinal cord, especially in this case because there is a labored breathing. It's at the level between C1 to C4. Bilateral corticospinal tract are involved, therefore quadriplegia. Bilateral dorsal column are involved, therefore loss of position sense and touch sensation. Bilateral spinothalamic are involved, so loss of pain and temperature sensation. But most importantly, it is also involves compromised respiration because there is reduced respiratory muscle strength because all the muscles are paralyzed, increased secretions due to autonomic dysfunction, and also increased retention of these secretions within the lungs because there is ineffective coughing. So usually such patients require ventilator. Now coming to the process of spinal tap or lumbar puncture. This is a procedure done to withdraw CSF or introduce drugs in the subarachnoid space. So the purpose is either diagnostic, which is done to withdraw CSF and do the analysis tests on that. Therapeutic purpose, wherein we introduce either anti-malignant or antibiotics, or most commonly it is done for anesthetic purpose, what we call as spinal anesthesia. The position of the patient is either he's sitting or lying down on one side, what is called as lateral decubitus, and the patient takes the fetal position by completely flexing the vertebral column to separate out the spines. Precautions which you have to take before doing spinal tap will be check whether there is intracranial pressure is normal by doing ophthalmoscope and ruling out papilledema. Check that there are no major lumbar vertebral pathology, and do not forget to take patient's consent after explaining the procedure. The usual site for doing this procedure is between L3 and L4 spines, or the needle will be introduced between L4 and L5 spines. So certain anatomical knowledge we need to know. The first one is the presence of lumbar cistern. We know that spinal cord ends at the level of L1, but the subarachnoid space continues all the level way down to S2 level, that is second sacral vertebral level. So between L1 and S2, there is a roomy subarachnoid space filled with CSF. The only structures there are the chorda equina with phylum terminale. There is no CNS structure. So it is an ideal site for introducing a needle and either to introduce drugs inside or to withdraw the CSF from there. The second thing which you should know is how do we identify the site of this injection or site of this lumbar puncture. So first identify the highest point of iliac crest. Go along that plane to reach the midline. The bony point which you hit there is the spine of L4 vertebra. So you put your finger just above or below to find whichever area is roomy. If you are doing the lumbar puncture above this bony point, then you are doing it between L3 and L4. If you are doing it below this, then the procedure is being done between L4 and L5. The next thing you should know is why are we asking the patient to take a fetal position? That will sort of separate out the vertebral spines that is needed for introducing the needle between the vertebral spines in case of lumbar vertebrae. The last one is you have to know the list of structures pierced by the needle. We will tell you the procedure here and tell the structures pierced as well. So the first thing what you are doing is once the patient has been made to lie down or take a sitting position, first clean the back area with complete aseptic precautions and drape the area. Anesthetize the back using 1% or 2% lidocaine. Do the entire procedure wearing gloves and mask. You should, as a doctor, should not introduce infection to the subarachnoid space. Introduce the spinal needle. Either of 20 or 22 gauge needles are used. When you're pushing the needle through the layers before reaching the subarachnoid space, it will be facing resistance. But when it finally enters the subarachnoid space, there's going to be a sudden cessation of resistance resulting in a popping sensation. So that's a classical understanding that you have now entered subarachnoid space. So once you have made sure that you have entered the subarachnoid space, remove the needle from that spinal needle and only the cannula will be left in place. So the CSF starts flowing out. If it is bloody, so then allow for one or few drops to drain it out, but then attach the manometer, find the initial pressure. If in case you are doing it for diagnostic purpose, manometer itself will collect the first test tube CSF, collect CSF in 3 more test tubes. If you are doing it for the purpose of anesthetic purpose, then introduce the anesthetic drug. If you are doing it for the therapeutic purpose, introduce the anti-malignant or antibiotic, whatever drugs were required to be introduced. So as I said, as the needle passes through either between L3 and L4 or L4 and L5, the structures pierced are from outside inwards, skin, superficial fascia, supraspinous ligament, interspinous ligament and ligamenta flava, then dura mater surrounded by extradural connective tissue, and finally the thin arachnoid mater. After the procedure is completed, we should watch out for few complications. Almost every patient has a headache. So some amount of headache is normal. It will go off within a day or so, but any extra headache has to be watched carefully. Other complications are infection, which probably can be avoided. And thirdly, brainstem herniation. Again, this can be avoided if we have already made sure that intracranial pressure was normal before we started with the procedure. Thank you very much. Hope you enjoyed this video. Please do visit this site for other such videos.